Hey there, everyone. My name is Andrew Shedd with SonoEd, and today we're going to be talking about the EFAST exam. If you've seen my first lecture, that was an introductory lecture to the physics and basics of ultrasound. And if you haven't listened to that yet, or if you're new to ultrasound, I would recommend you go ahead and listen to that one first. It's only about 15 or 20 minutes long, but is a good introduction to ultrasound and how we're going to use it in the emergency department. But today I want to talk about the EFAST exam, which is probably one of the most common ultrasounds performed at the bedside in the emergency department. The EFAST or FAST exam actually began being used in the 90s to evaluate for free fluid in the abdomen in patients who were critically ill and had had traumatic injuries. Soon thereafter, ultrasound also began to be used to look at the heart to assess for fluid or blood around the heart, and so it changed from focused abdominal sonography in trauma to focused assessment with the sonography in trauma, or the FAST exam. And in recent years, some lung views have been added, and so now we often refer to it as the EFAST, or extended focused assessment with sonography in trauma. And so this is an exam that looks for multiple things in the setting of trauma. To start, we're going to perform multiple abdominal views to assess for free fluid in the peritoneum. We're also going to perform at least one cardiac view and at least one lung view per side. And what are we looking for? Well, in the abdomen or peritoneum, we're looking for free fluid, which is often blood. We're also looking around the heart for fluid in the pericardium, or blood, and evidence of tamponade. And in the chest, we're looking for evidence of pneumothoraces or hemothoraces. Now, you'll often hear me use the term fluid or blood interchangeably because on ultrasound, it can be hard to tell the difference. So we typically refer to it non-specifically as fluid, although in the clinical setting, it may be interpreted as blood. To begin, we're going to start in the right upper quadrant of the patient. You could start in other quadrants or perhaps the cardiac view if clinically indicated, but in general, I like to start in the right upper quadrant. We're going to perform this view in the long axis with the indicator of the probe towards the patient's head, as is standard. And we're going to identify several structures: the liver, the kidney, and the space in between them, which is Morrison's pouch. We're going to scan through this pouch looking for any free fluid, which should be black if it's acute blood. We're also going to identify the diaphragm and the costophrenic angle above the diaphragm. And we're going to look for mirroring artifact of the liver above the diaphragm. If you recall from the introductory lecture, this is a normal finding. Here's an example of how to place the probe in the patient's right flank with the indicator towards the patient's head. And here's a couple of views that you might obtain. Remember, the indicator is on the screen left, and that corresponds with the patient's head. The first large structure you should see is the liver, followed by the kidney, and the potential space between them, which is Morrison's pouch. Also identify the hyperechoic curvilinear structure just above the liver, which is the diaphragm. And you see these structures also in the image below. You'll note that above the diaphragm there is mirroring artifact of the liver, which is a normal finding and an artifact of the ultrasound waves as they traverse the diaphragm. The absence of this mirroring artifact will occur in the presence of fluid in the chest, as we'll see in the next slide. So now let's compare normal to abnormal findings in the right upper quadrant. In this first image, you'll see the same liver, kidney, and Morrison's pouch that we saw in the last slide. And if we were to put a stripe of fluid in Morrison's pouch, it would appear as an anechoic or black stripe, seen here. Now in the image at the bottom of the screen, you'll notice again we have liver, kidney, we can see the diaphragm, and we can also see the mirroring artifact of the liver above the diaphragm. If we were to replace that mirroring artifact with fluid, it would look something like this. Now this is a large collection of fluid in the chest cavity, and you actually see that the liver and the kidney are far to the right side of the image, and you see two hyperechoic curved structures, which are the two different pleura. One is adherent to the diaphragm towards the right side of the screen above the liver and kidney, and you also see some hyperechoic structure on the left side of the fluid, which is the visceral pleura, and the large collection of fluid is seen here in the chest. Let's look now at a video of the right upper quadrant. You'll see two things in this video. One, you'll see a stripe of anechoic fluid in Morrison's pouch, and you'll also see that there is normal mirroring artifact above the diaphragm, so there's no evidence of fluid or blood in the chest at this point. Here's a video of the right upper quadrant where we're focusing more on the thoracic cavity, and you'll see a large collection of black fluid in the chest. Now this turned out to be a pleural effusion, but you can see that the lung, as it's surrounded by fluid, appears more like a consolidated solid structure than we're used to seeing it, and you can actually see the tips of the lung swimming in that fluid. You can see the liver and the kidney again to the right side of the screen, but we're more focused on the chest in this view. Let's move on now to the second view I'd like to obtain, which is what I refer to as the suprapubic view. You'll also hear this view referred to as the pelvic view or the bladder view or the retrovesicular view. However, I prefer suprapubic view because it refers to where we're placing the ultrasound probe. I prefer to obtain this view in the long axis or sagittal plane with the inferior aspect of the probe placed over the pubic symphysis. This helps us identify first the urinary bladder, and then I will tilt the probe cephalad to look more into the patient's peritoneum. And then we're going to scan right to left, looking for fluid in the peritoneum. In the male, this will be deep to the urinary bladder or retrovesicular, and in the female, it depends on how much fluid there is. The most dependent portion is deep to the uterus in the pouch of Douglas, and that will be the first place that fluid will accumulate. However, you'll also want to assess all around the uterus and deep to the fundus of the urinary bladder. Here's an example of how to hold the probe on the patient, oriented in the long axis. With the indicator towards the patient's head, that will correspond with the left side of the screen, and you'll see that the image you'll obtain with urine in the bladder makes the bladder appear more triangular. You'll also see that the peritoneum is then cephalad to that, and you can see bowel gas from the loops of small bowel. You can also obtain this view in the short axis, and this is an example of how you would orient the probe. The image you obtain will have the urinary bladder look more symmetric or block-like, and with the indicator towards the patient's right, that will correspond with the left side of the screen. Here's the urinary bladder filled with urine, and deep to that is a portion of the uterus. In the female, part of the body of the non-gravid uterus can be in the peritoneum. However, if you're angled more inferior or towards the cervix of the uterus, you may be in fact looking at the pelvis. This also, in the male, would be true if you saw the prostate deep to the urinary bladder. You would be angled into the pelvis. So in this view, it's important to remember that when we're assessing for fluid in the peritoneum, you need to scan cephalad up through the fundus of the urinary bladder to ensure that you're looking into the peritoneum for fluid. Here's an example of a long axis view, and as the video stops, you'll see that there's a large collection of free fluid above the urinary bladder. I also want to play this video again because you'll see that there's also fluid surrounding the loops of bowel, and there's a bit of fluid deep to the uterus in the pouch of Douglas. That is often the first place that you'll see fluid accumulate. Here's an example of a short axis view where the physician sees the urinary bladder and the uterus, and in this patient, because I was there, recall that this was actually the cervix, and that as we obtained this view, we did not see any free fluid. However, as we scan cephalad up into the patient's peritoneum, you can see that there is a decent collection of free fluid deep to the urinary bladder. I want to play this video again because it exemplifies why it's important to ensure that if you use the short axis view, that you scan cephalad up through the fundus of the urinary bladder to ensure that you're assessing the peritoneum and not the pelvis for fluid. So again, seen here is the urinary bladder and the uterus, and note that as we scan cephalad, we now see the free fluid up in the peritoneum. Let's move on now to the left upper quadrant view. This can be one of the more challenging views to obtain because the left kidney often lies more posterior in cephalad than on the right side. This often requires placing the probe near the mattress, and again we're going to be in the coronal plane or long axis view. We're going to find the spleen, the kidney, and the splenorenal space between them to assess for fluid. It's also very important on the left side to look all around the spleen in the perisplenic space for fluid. This is because, unlike on the right side, fluid on the left side often collects around the spleen first before the splenorenal space. Finally, you'll want to identify the diaphragm and look for mirroring artifact of the spleen above the diaphragm. Here's an example of how to place your probe in the patient's left flank and the corresponding images that you should obtain. The indicator is again towards the patient's head, corresponding with the left side of the screen. The first large structure you should identify is the spleen, then you'll see the kidney and the splenorenal space between them. You'll also see the hyperechoic diaphragm and the mirroring artifact of the spleen above the diaphragm, which is a normal finding. On the ultrasound image at the bottom, you'll see the same structures, but also note that there is a positive finding in this image. There's a small collection of fluid at the superior and anterior aspect of the spleen, seen here. This exemplifies why it's very important to scan all around the spleen to assess for small volumes of free fluid. Here's a video of the left upper quadrant demonstrating a decent collection of free fluid around the spleen. You'll notice that up in the chest there is normal mirroring artifact. Here's an example of the left upper quadrant that demonstrates two positive findings, so I want you to make sure you can identify both. At the near field, at the tip of the spleen, you'll see a small collection of fluid. And also, up in the chest above the diaphragm, you'll see that there is also a collection of black anechoic fluid, as noted by the absence of the mirroring artifact. Please ensure that you can see both of these positive findings before moving on. Here's an example of a large left pleural effusion as demonstrated by the large collection of black anechoic fluid in the chest. You'll see that again the lung appears more consolidated and dense and can be seen moving around in the fluid. What is the sensitivity of ultrasound for free fluid in the abdomen? Well, it's about 200 to 250 milliliters depending upon the user. CT is more sensitive and DPL is the most depending upon the criteria used. Remember that if free floating bowel is seen, then there's at least 1 liter of fluid present. Let's move on now to the cardiac view, which in general is going to be a subxiphoid cardiac view. This is often the easiest to obtain. However, if the patient has a lot of abdominal pain or has a large or protuberant abdomen, this view may be challenging, and in that scenario I would use a parasternal long view. To obtain the subxiphoid view, you're going to place the probe under the patient's xiphoid process with the indicator to the patient's right. This is assuming that the machine remains in an abdominal setting as it was for the prior views. If, however, you switched your machine to a cardiac mode, it may be possible that the indicator would switch to the other side of the screen, depending on how your machine is set up. But for now, we'll assume that the machine remains in an abdominal mode, and so we're going to orient the probe with the indicator to the patient's right. We'll first identify the tip of the liver, and then we'll sweep the probe leftward looking for cardiac activity. Try to keep some liver between the probe and the heart because this will improve your acoustic window and image quality. Here's an example of how to orient the probe on the patient, and then an example of an image that you should obtain. With the indicator to the patient's right, that will correspond with the left side of the screen. We can first identify the liver tip in the near field, and then the right ventricle and adjacent left ventricle, and the corresponding atria. The pericardium is the potential space around the heart which appears hyperechoic. Here's a normal video of a subxiphoid view wherein you can identify the liver, right ventricle, left ventricle, and right atria. You'll also see that in the pericardium there is a trace amount of pericardial fluid right at the tip of the liver adjacent to the right ventricle. This is likely a normal physiologic finding. In this video of the subxiphoid view, you'll see a large collection of fluid around the heart, in fact very large. However, the heart does not appear to be in tamponade, as there is no diastolic collapse of the right ventricle or right atria, which would suggest cardiac tamponade. This was likely a slow-developing medical pericardial effusion, as if this much blood accumulated acutely in a traumatic setting would almost certainly result in tamponade. In this next video, we see again a large collection of fluid in the pericardial space. However, this time the heart appears much more distressed. It's tachycardic, and you can see that the right ventricle appears collapsed throughout the cardiac cycle. There are more advanced techniques to assess for cardiac tamponade, particularly in the early phases. However, in general, I just look at the right ventricle and right atria, and I ask myself if they are functioning in correspondence with the left side of the heart or if they appear collapsed in diastole. Let's move on now to the lungs and discuss how we're going to evaluate for pneumothoraces. This is a very easy technique to learn so that you can be evaluating the patient for this condition while the chest x-ray is still being ordered. In general, the linear probe is preferred, but the curved probes will also work, especially after you have more experience with this technique. To perform this exam, you're going to place the probe in the long axis or parasagittal plane on one side of the anterior chest wall. In general, start at the third or fourth intercostal space in the midclavicular line and identify 2 ribs and their associated shadows, and then look for the hyperechoic pleural line between the 2 ribs. And it's along this pleural line that we're going to assess for lung sliding or motion. We'll then repeat this exam on the other side of the chest. Here's an example of how to place the probe on the patient's chest wall, and we're going to orient the probe with the indicator towards the head. This is the image you should obtain, and the first thing you'll see are two ribs and their associated shadows, and then a hyperechoic pleural line between the two. It's along this pleural line that we're going to look for lung sliding. In this patient, the left lung is normally aerated, such that the visceral and parietal pleura are interacting as the patient breathes in and out. On ultrasound, this appears like lung sliding. You'll see that along the pleural line between the two ribs there is horizontal motion that is often described as ants marching. You'll also see that it's evidenced by small reverberation artifacts or comet tails extending down from the pleural line. If, however, you place the ultrasound probe over pneumothorax, as in this patient's right chest, you'll see that the visceral and parietal pleura are unable to interact as the patient breathes because of the presence of air between the two pleura. On ultrasound, this appears as the absence of lung sliding. Now you may see that there's motion of the soft tissues as the patient breathes or the ultrasound probe is moved. However, along that pleural line, you'll see that there is no horizontal motion or no lung sliding. This is evidence of a pneumothorax. What would happen if you placed the ultrasound probe right over the edge of the pneumothorax? Well, you'd get an image like you see here. In this image, you see that along the pleural line, there is a portion of which there is lung sliding and a portion of which there is not. And you can see that as the patient breathes in and out, this lung point moves. This is not always seen, but is certainly an interesting finding. Let's talk more about M mode, which is another technique to assess for pneumothorax. Remember that in M mode, M stands for motion, and the machine is going to drop a single vertical line from the probe and then plot motion along this line over time. Here's an example of a normal M mode image. At the top of the image, you'll see a B mode image in which you can see the pleural line, and in the M mode graph at the bottom of the image, you'll see the pleural line at the same depth. Deep to this pleural line, you need to ask yourself if the image appears more pixelated, like a sandy beach, or more striated, like a barcode. If it appears more pixelated, we refer to that as the Seashore sign, and this is evidence of normal lung sliding or the absence of a pneumothorax. If, however, deep to the pleural line it appears more striated like a barcode, then this is evidence of a pneumothorax because of the absence of lung sliding. Here's an example of these two images side by side. Identify first the pleural line in both images, and then look deep to the pleural line and ask yourself if it appears more pixelated like a sandy beach or more striated like a barcode. The top is evidence of a normal lung without a pneumothorax, and the bottom image is evidence of a pneumothorax. If you're uncertain, check multiple rib spaces. Checking multiple rib spaces can also be used to estimate the size of a pneumothorax after you've diagnosed one. If you're uncertain still, try to use the other technique opposite of the one you started with. For instance, if you tried in B mode and are uncertain, try M mode, or vice versa. Let's talk for a bit now about how we're going to integrate these findings into our medical decision making. Regarding the peritoneum and the presence or absence of free fluid, it really depends on how stable the patient is. If you have a fast exam that's positive for free fluid in the peritoneum and they are stable, then you may proceed to CT. If, however, they're unstable, then it depends on the facility you're working at. If you're at a trauma center, then the patient's going to need a trauma surgeon, as they may need an exploratory laparotomy. However, if you're at an outlying hospital, then as you continue to resuscitate the patient, you're going to need to arrange for an emergent transfer to a trauma center. If the FAST is negative, then you need to either observe the patient or proceed with the CT scan as clinically indicated. If they're unstable, then you will resuscitate the patient, consider other causes of their hypotension, and if you still believe it may be due to an intra-abdominal injury or hemorrhage, then you need to consider repeating the FAST exam versus a DPL or perhaps an exploratory laparotomy. If the patient stabilizes, then you may proceed to CT. There are a couple potential causes of false positives. In the right upper quadrant, the gallbladder can appear like a collection of fluid, as could a renal cyst or a vessel, such as the IVC or aorta. Pre-existing ascites can also complicate the interpretation, as it will appear as fluid in the peritoneum. A couple potential false negatives of the FAST exam would be a small volume of fluid that is too small to see on ultrasound, or perhaps failure of the operator to scan completely through the dependent areas. If the injury is subacute and the blood is thrombosed, this will also be more challenging to pick up on ultrasound. because the blood will be clotted and echogenic instead of black and anechoic. Here's an example of the gallbladder in the right upper quadrant that can mimic free fluid. However, please note that the gallbladder has distinct boundaries and rounded edges. You'll also see the IVC in the far field deep to the liver, which could appear like fluid as well. There are a few things that may limit your ability to perform the FAST exam. A morbidly obese patient could be hard to get adequate views on. Subcutaneous air might cause an artifact, and pain and tenderness over the site might limit your ability to place the probe on the patient. Pre-existing ascites can also complicate the picture as we discussed, and remember that retroperitoneal injuries or hemorrhage are difficult to pick up with ultrasound. And finally, late-term pregnancy may also present a challenge. So in summary, the eFAST exam is very safe, rapid, and a non-invasive way to facilitate the early detection of hemoperitoneum, hemo or pneumothoraces, or cardiac tamponade. Recall that to perform this exam, we're going to perform at least one cardiac view, 3 abdominal views, and at least 1 lung view per side. Remember to scan through each abdominal region completely, and do not forget to look above the spleen on the left and above the diaphragm on both sides. Thanks for your time and attention to this lecture. I do hope you found it educational and informative, and as always, please feel free to contact me with any questions or concerns, and please check back in the near future for more lectures.